Anurag Leela is an additional professor in endocrinology department of St. G.S. Medical College and KEM Hospital, Mumbai. His areas of interest are pituitary and adrenal disorders. Dr. Anurag will be talking on hypoglycemia, causes and solutions across all age groups. I invite Dr. Deepak Lote, Senior Physician of Akola, and Dr. Kamal Kishore Dole, Senior Pediatrician of Akola, to please chair this session.
I would like to thank the organizers, Leela madam and everybody else for this privilege. And as we all know, the hypoglycemia is a dangerous complication, can be devastating and sometimes fatal. 45 years ago, any diabetic patient who used to come in coma, we used to give them 25% or 50% dextrose because we didn't have immediate glucose levels to be monitored. That was not available. Later on, with the advent of drugs, sulfonylureas, the hypoglycemia used to be protracted for not hours but days. And I learned it the hard way when I discharged the patient and he came back in hypoglycemia next day, and I had a scolding of my life from my boss. Also, with the advent of newer insulins, the hypoglycemia can be, there can be unawareness of the hypoglycemia. Symptoms may be less. So I'm sure Dr. Anurag will highlight and hold Dr. Anurag.
Thank you, sir. So this is a pre-lunch session on hypoglycemia. So many of us might be having reactive hypoglycemias by now, post breakfast. So I'll be talking on hypoglycemia. It will be more of, again, shifting there to more towards a medical talk. Previous talks were more social, psychosocial, mental. So those aspects were there. So I'll bring back to probably a classroom again. And so causes of hypoglycemia in a diabetic patient, we all agree it is a mismatch of the drug and the food. So drug overdose is the one. But we always do a creatinine, we try to rule out adrenal causes, or in a case of sepsis and critical illness, there may be hypoglycemia per se because of the cytokines. So this is a common condition. In a diabetic patient, we want to look at all these things. As I mentioned, in a pre-diabetic or obese individual, reactive hypoglycemias are not uncommon. That happens post-meal. So people will say usually by 11 and 12 they feel very hungry, they have to eat something in between. It precipitates their migraine, so it's a reactive kind of hypoglycemia. And it's kind of a reactive kind of hypoglycemia, which can be managed with diet modification and a low-carb diet. So these are the two common situations which we all deal with. At our department at KEM, our expertise is pediatric endocrinology and endocrine oncology. So that is our area of work which I would be showcasing in the next few cases and a few learning points through that. So the 67-year-old man comes with episode of sweating and tremor, dizziness and confusion. It is happening for some time, and people in the family also know. You give him some biscuits and tea, he's okay after 15 minutes, 20 minutes, and this has been going on for years together. Even in a doctor family, I know a pediatrician, her mother had these symptoms for around 15 years before actual diagnosis was made. They could manage it for somehow because it's a morbid condition and they know how to manage it. So symptoms of hypoglycemia can be neurogenic, which is like active sympathetic activation which happens, or neuroglycopenic because of a low glucose to the system, cerebral system. So these symptoms we all are aware of hypoglycemia. But this patient is not a diabetic, he's not on any medications. Why should this person go into hypoglycemia? So in India, like Jain people fast even for 7 days. They don't even take food, only water. Some of them do it for 30 days. They don't go into hypoglycemia. So body doesn't allow the glucose to go below a point. So if the sugar is going below a point, there has to be some pathology which is doing it. So per se, because of not eating, one should not go into hypoglycemia. So these are the cases we are talking about. He's getting a sugar every morning, the sugars are falling down. There should be some reason why it is happening. So whenever there is a hypoglycemia, classically Whipple's triad should be followed. There were signs and symptoms of hypoglycemia. Hypoglycemia was documented, and after giving sugar or dextrose, the hypoglycemic symptoms recovered. So as an endocrinologist, whenever a case of hypoglycemia comes, mentally we go through this picture. Yeah, we are dealing with hypoglycemia clinically. Coming to the biochemical nature, so whenever in a critical care situation or in a casualty a hypoglycemic comes, so for all the physicians or the people working in the intensive care or casualty, it would always be good to store a serum sample, if possible, before running the dextrose drip, or parallelly at the same time if they can document a critical sample. Because the critical sample will give us the diagnosis. Once you have given the dextrose, whatever level of insulin or a fasting insulin or a random insulin or a C-peptide you will do will not give us a diagnosis. So if the physician is on board, or even if you get a call, please ask them to draw a sample which is a critical sample. And at the time of low sugars, we would like to do insulin and C-peptide to get a diagnosis and prove it is an endogenous hyperinsulinemic hypoglycemia. Because at the time of hypoglycemia, there is no business for the insulin to be released. So if I am having hypoglycemia and still my insulin levels are high, still my C-peptide is high, that means this is something pathological and it should not physiologically happen. So these are the cutoff we classically use for hypoglycemia: 55, insulin more than 3, C-peptide beyond 0.6, and the ketones has to be negative, because the ketones cannot be formed in the state of excess insulin, whereas in starvation the ketones will be high. So this individual who had hypoglycemia was put to a 72-hour fast test. Time to hypoglycemia, he went into hypoglycemia within the 24 hours. Glucose was documented to be 53. At the time of low glucose, there is no business for the insulin to be there in the blood system, which was 21. C-peptide was high. Urine ketones was negative. So it is an endogenous hyperinsulinemic hypoglycemia. And the most common, or insulinoma per se are rare, but in this situation, insulinoma becomes the most common cause for his hypoglycemia. There are other conditions. It could still be insulin autoimmune syndrome, post-gastric bypass or post-gastrectomy. You can go into hypoglycemias, which I will show you a few cases. Or he might have taken insulin, or he might have taken sulfonylurea, and that might have led to the problem, or the differential diagnosis which comes to my mind at this stage. But most common, I will look for an insulinoma. So clinically I have documented, biochemically I have documented, and now I think he has an insulinoma, so I will image him. Imaging wise, insulinomas are micro lesions, so looking at them becomes at times difficult. So we have to do a very dedicated CT scan, thin cuts, enhancement pattern has to be looked for, and the DOTA scans have made our life easy. But the DOTA scan will pick 50% of the cases of the insulinoma. So in this case, we were lucky that the insulinoma was picked up on the DOTA scan. Now this patient can be referred to a laparoscopic pancreatic NET removal or enucleation, and he would do fine. This lady, 32-year-old, symptomatic for 4 years, had seen so many specialists, has been treated by psychiatrists for a year together because of the hypoglycemic symptoms. She was, because of the altered sensorium and all, and the behavior was very altered. So he was on antipsychotic medications for a year together. His weight was around 135 kgs when she has come because of hypoglycemia, and they compensate by eating again and again. And you can see the critical sample, RBS was 22, fasting insulin was 102, C-peptide is high. So we have followed the clinical, biochemical, and the radiological. The radiologically, the DOTA scan and the CT scans were not able to pick up the lesion. But by 2010 onwards, we had this exenidin scan. So in her case, the exenidin could pick up the lesion in the tail of the pancreas. And so 50% of the time the DOTA scan will pick up, but now we have exenidin scan which will pick up these lesions, and had made our life very easy. In the past, we would have done a very difficult intervention radiology technique or an intraoperative sonogram to look for these things, but now pre-operatively we are very sure about the diagnosis because of the exenidin, which has a sensitivity up to 90% in these cases. She's underwent surgery. Then she has lost now around 50 kgs of her weight. She got married recently. This was a 2 months follow-up when she had come for a follow-up. From 153, now she was 90 kgs on the last visit. She has recently married. And she always go and tell, when we take her picture, she said, show my picture to everyone, show my case to everyone, so that everyone comes to know that such a condition existed and I was labeled as a psychotic for years together. So she's very grateful to us for the diagnosis and the management in this case. So since I said 2010 onwards, we had access to Exenedin because TMH and RMC being nearby, so all these scans were possible, and Ravi has done all the study and Robin has done a few studies on the imaging of these. So if we look at the CT scan, DOTA scan and Exenedin scan has the highest sensitivity as compared to the three. But CECT is equally good because if the lesion is there, it has to be seen on the CT scan. So in hindsight, we combine all the investigations. So Exenedin based PET scan with a CECT is an important test to diagnose insulinoma. But diagnosing radiologically is important only if we have fulfilled first the clinical, biochemical, and third is the radiological criteria. We should not step the jumps. Patient comes to a casualty hypoglycemia, get a CT scan done. We will always end up missing the diagnosis or misdiagnosing the cases. So jumping not the basic steps is very important when it comes to this. I'll show you some cases later. So usefulness, is Exenedin scan only sensitive? No, it makes it more specific also, because normally DOTA scan, which there was a lesion on the uncinate process if you look at on the DOTA scan, but uncinate has a normal physiological uptake on the DOTA scan. But the same uptake was there on the Exenedin, it made it very specific. No, we are dealing with an uncinate process, insulinoma, and the patient was operated for the same. Similarly, there was no lesion in the pancreas on the DOTA scan or the Exenedin. But Exenedin could pick up a jejunal insulinoma, which is an ectopic insulinoma. So insulinoma which was not in the pancreas but in the jejunum or the midgut part. So DOTA scan was also picking it up, but we were not sure about it. But when the Exenedin picked it, made it very specific, and the jejunal lesion, and the patient was cured of hypoglycemic symptoms. Similarly, in the MEN1 syndrome, there can be multiple neuroendocrine tumors. Some may be secretory, some may be non-secretory. So which lesion is secreting insulinoma or insulin can come from the Exenedin scan and not from the DOTA scan, which will be positive in any of the NETs which may be secretory as well as non-secretory. This again, so now we have got a good modality. Now we start using or abusing it. So that is what I'm trying to hold. Judicious interpretation of the Exenedin scan was very useful. So this is a 20-year-old pharmacy student who had multiple episodes of hypoglycemia. Random blood sugar was low, treated with dextrose. And at the time of critical sample, you can see the random sugar was low, insulin was high, C-peptide was high. So he was diagnosed as a case of endogenous hyperinsulinemic hypoglycemia. And since he's in Bombay, he's a pharmacy student, he has access to all the medical care. He comes to us with all the 3 scans. He has done a CT scan, he has done a DOTA scan, he has also done an Exenedin scan. And Exenedin scan is showing a lesion in the tail of the pancreas. But again, when we took the history, there was something not fitting. The kind of hypoglycemic symptoms he was having were not very consistent. The history, the way it has evolved was not very consistent. So we were digging into the history again and again. Then we said, okay, we have to do your fast test again. We did a supervised fast test. We put him in an ICU bed where he has no access to any medications or insulin or any sulfonylurea. The parents were told about the same thing, that we are doing this, we are suspicious about it, we are not saying it is there. It may be there and we want to rule it out before operating the pancreatic lesion. So supervised fast test was done, random sugar fall to 55 at the max, insulin C-peptide were low, he had ketones. So on a starvation test, he had ketones and sugar didn't fall beyond a point. And actually, on interrogation, he said, I was taking sulfonylurea. And at the time of the first test, when the doctor did a fast test on the first occasion, he has taken sulfonylurea. And because of the sulfonylurea, hypoglycemia happened, insulin went up, C-peptide went up. and the exenidin, whatever lesion picked up on the exenidin is just a false positive lesion and it's not actually an insulinoma. So we have seen many cases of Munchausen syndrome who have been referred across, especially from various interiors of Maharashtra, and you cannot believe them that such a benign looking person might be doing it or not. So that should, I'm not saying I should put that as a first diagnosis, but it should be one of the differential diagnoses when I'm dealing with such cases. Other than the scans, the nuclear scans also help in theranostic, and especially the DOTA scan, and we have that lutetium-based PRRT therapy, especially for the metastatic lesions. This individual was very lucky that even with the liver metastasis at baseline and widespread metastasis, with the PRRT, the lesion was in remission for years together in this case. Other than insulinoma, I should also look for MEN1 syndrome, because insulinoma can be a part of MEN1 syndrome, what we call as PIT-PAN-PARA. The pituitary adenomas can be there, parathyroid adenomas, so a serum calcium can give us an answer, a serum prolactin can give an answer. So we should look for the clinical and the biochemical signs of MEN1 syndrome if it might be existing. Again, this man was around 150 kgs and he lost 50% of the weight and he was 75 kgs on follow-up once the insulinoma, which was a macroinsulinoma on the tail of the pancreas, was removed. Another case, 43-year-old female with a short duration of symptoms, and she had hypoglycemia, and critical sample random sugar is 36 and insulin levels are high, C-peptide is high. So endogenous hyperinsulinemia, and the CT scan was done, there was no pancreatic lesion was found. So at this stage she was referred to us. But you look at this case, the insulin levels are in 3 digits. So this is a usual case of insulin autoimmune syndrome, where there are antibodies to the insulin which are formed, and they may have insulin which is released over a period of time and getting into hypoglycemia. So this is a classical case of insulin autoimmune syndrome, short duration of symptoms. It was 10 days of history, not a very long history. So it is an insulin autoimmune syndrome. You can prove by doing an anti-insulin antibody which came out to be high. And some of the drugs which can do is, one of the drugs is an anti-thyroid drug which classically does it. And he had history of being diagnosed with hyperthyroidism, was started on neomercazole for the same, and that precipitated it. And insulin level more than 100 at the time of hypoglycemia, we should think of insulin autoimmune syndrome or a Hirata syndrome, and a shorter duration of symptoms. And there is a ratio of C-peptide to insulin is what we would suggest it is more towards an antibody. And there are n number of lists. We did a systematic review and we could collate around 33 drugs which can cause this syndrome. If you ask them, they are not very commonly used drugs, but one of them can cause such a syndrome. Even post-COVID, we have seen as an post-COVID autoimmune hypoglycemias, which were anti-insulin antibodies because of immune dysregulations. During COVID, we got a cluster of patients like that as well. Going to the next case, this patient has undergone proximal gastrectomy, esophagogastrostomy, because of some gastric wall injury which has happened. Then he was getting into hypoglycemias. A critical sample was done. Random blood sugar is 54, insulin is 4, C-peptide is high, suggestive of endogenous hyperinsulinemia. At an outside center, they did a DOTA scan, and they picked up some lesion in the distal pancreas. And then they did a distal pancreatectomy. Actually, that turned out to be accessory spleen, because spleen take up a DOTA scan. So at this stage, when he was referred to us, we know that this is a case of after gastrectomy, people tend to get into beta cell hyperplasia, and it is a persistent hypoglycemia attack after post-surgery. Even after the second surgery, even after the so-called distal pancreatectomy, he was having persistent symptoms. So in this case, this is a case of post-gastric bypass residioblastosis. So the clinical history is very important in this case, and this could be proven by doing an exenidin scan which showed a diffuse uptake in whatever residual pancreas he had. And we medically managed him by reducing the diet, putting him on an acarbose, and initially we were using octreotide to bring down his symptoms. And his symptoms got relieved and he could do his routine activities, started driving car, joined back his duty. So this is a case which also has to be remembered as a symptom. The history is very important, and the surgery can be for weight loss or it may be for some medical reason when there is gastrectomy which has been done. Another interesting case, 11-year-old, again random blood sugars were low, C-peptide and insulins were high. Even endoscopic ultrasound was done for the pancreas and they identified PNET. He's posted for surgery for that, and that is a time when we got a reference for second opinion. But when we looked at the values, the insulin value is very high, but the C-peptide was not very high. So that made us suspect that what is going wrong. Then again he was admitted in the ward. We had some suspicion. So one of our residents was very suspicious that he's doing something wrong, and with the levels we thought he's taking insulin from outside. So then in the ward, he has hidden the insulin in the toilet in the ward, and he was taking insulin when he went to the toilet. And the resident caught that insulin from the toilet. Then we asked the wife. The wife could find the insulin in the drawer of the car, not at home. So, and it turned out to be he was taking insulin. And we have seen such patients who have undergone pancreatic surgeries also. So Munchausen syndrome can go to an extent where they can inflict surgeries on themselves. And it is like we should be cautious about such cases as well. Now coming to some uncommon cases, if I am critically well, these were the conditions we discussed, where it could be insulin, and if you take the analogs, it will not be detectable even in the test. If you are taking sulfonylurea, you may do a urine sulfonylurea test which is available in certain centers in India, but a urine sample has to be collected and transported to them. Coming to clinically unwell cases, we get some rare cases like this, where a very big tumor in the body may produce insulin-like growth factors, as in this case of CA breast. From TMH, we will get one case once in 3 to 6 months like that, with big tumors, mesenchymal tumors producing IGF-2 will produce hypoglycemia. These are straightforward diagnoses, and we have to palliatively manage them with steroids to counter the action of IGF-2 in these cases. Adrenal insufficiency can manifest, especially in children. Hypoglycemic seizures is one of the commonest presenting feature of cortisol deficiency when they have. Even in adults, it can be central or primary adrenal insufficiency or secondary adrenal insufficiency. In this case, this 65-year-old presented on diabetes. He was having multiple episodes of hypoglycemia. Even after stopping diabetic drugs, his fasting hypoglycemia persisted, and which was all because of the cortisol deficiency he was having. So pan-hypopituitarism, especially the steroid deficiency, can lead to hypoglycemia in these cases. Hyponatremia is well known, but hypoglycemia is also a presentation of hypocortisolism. Now special considerations, childhood and neonatal age groups, hypoglycemia when they come. Like this child was referred to us, initially was managed in a intensive care setting in the other hospital. So where he had hypoglycemia on day 1 of life, which was persistent, he required glucose infusion drip, and then he was initially diagnosed as a fatty acid oxidation defect and was put on certain treatment. Diazoxide was started, so symptomatic treatment was started. Even at the critical sample, the insulin level was low. So we are not dealing with an hyperinsulinemic hypoglycemia. When he was referred, when we did the test, the cortisol was low, the GH, IG. So he is a case of pan-hypopituitarism, and all the levels are low, including thyroid, growth hormone, cortisol. Even an MRI showed an ectopic posterior pituitary, so which was very, very conclusive of the diagnosis. So it's a case of combined pituitary hormone deficiency. And once we started him on Hyson and growth hormone and thyroid hormone, his hypoglycemic episodes could be taken care of. So, as a pediatrician, this is the chart which all of us follow symptomatic cases, we look for the hypoglycemias at various stages, and at a high risk, we monitor them and diagnose hypoglycemia based on certain cutoffs and manage them. The good part is most of the cases are transient, but few of the cases which come to us as a reference center are the persistent hypoglycemic cases, which is because of congenital hyperinsulinemic hypoglycemia in the neonate or infancy or childhood that they manifest. So in this case, the beta cell is active or overactive because of the mutation in the glucokinase pathway or the glucose metabolism pathway or the channelopathy. So we can have two kinds, various mutations, which can be ABCC8 is the most common, or we can get GLUD1, or in the metabolic pathway we can get certain mutations. So the beta cell is active because of the mutations and making insulin when it is not required. So these are the kids who present in infancy with hypoglycemia which is persistent. And the first case is because of a GLUD1 mutation, and the second case, similar cases because of a ABCC8 homozygous mutations. The channelopathies will not respond to diazoxide, whereas the metabolic defects will respond to diazoxide. So that's a difference once we get a diagnosis based on the genetic mutation. And once that is done, we can manage them, and those are diazoxide unresponsive, we can manage them with octreotide then. So octreotide is a very good drug in these cases. Subcute octreotide, we start with 50 microgram TDS and gradually build up to maintain the levels. So diazoxide has its own concerns because hypertrichosis becomes, and the child actually becomes a bhalu when they come for a follow-up. So it's very, very disappointing and not very good drug, though we have come out of a hypoglycemic concerns in most of the cases. Few kids also have fluid retention. So diazoxide is not a very kind drug, though it is required in those cases. And so we have been using that in the past. So then we were very happy with octreotide in the cases where they were diazoxide unresponsive. So then we thought, why not use octreotide in the cases which are diazoxide responsive also? So the concern was octreotide was to be given subcute 3 times a day. So I said, we do use insulin, so why not we can use octreotide in these cases? So that was accepted. Then we said, okay, we'll start a long-acting octreotide, which is monthly once injection. So same dose of subcute octreotide, we calculated and gave a long-acting octreotide. And octreotide comes as an injection which is 20 milligram and 40 milligram. So we used to call 3-4 kids at a time and give 5 milligram depending on their weight. So the cost of that octreotide LAR used to come low, and then we can sustain that octreotide injection on a monthly basis in these families. So we have now experience of using it in 15 patients, octreotide LAR on ongoing basis, which is a good injection and easy to manage. Once a month they take the injection. The cost is varied between 3 to 4 patients, and the response is actually good. And we are seeing how the child will outgrow. The concerns of growth and other aspects of nausea, vomiting, which we see in adults, was not seen in this cohort of patients with childhood. And other centers have also started using octreotide in such cases. So the treatment has become pretty easy in these cases, which used to be a difficult diagnosis in the past. So I'd like to conclude my slide in a hypoglycemia in a non-diabetic patient, clinical, biochemical, radiological. Again, if only on the radiology you can miss the diagnosis, don't read a radiological report. People end up doing pancreatic surgeries and get into diabetes and other complications. So, and it's more of like a CID approach when it comes to Munchausen. It becomes very difficult to confront the patient and the family because it becomes very difficult to handle that situation. We take the help of a psychiatrist once the diagnosis is done. A fast test is very important to rule out a problem. Syndromic associations, yes. Insulin autoimmune, when the insulin levels are very high, and look at the whole syndrome in managing these cases. Post-bariatric surgery, it is persistent hyperinsulinemic hypoglycemia, which can be managed medically. And the pediatric cases, hypoglycemia, which is persistent, can be because of adrenal insufficiency, which is primary or secondary, or overactive beta cells because of the mutation. Genetic tests are easily available these days. Once they are done, we put them on octreotide LAR. First we start them subcute octreotide and shift them to octreotide LAR in these cases. Thank you.
Thank you, Anurag sir, for sharing the cases of hypoglycemia, starting from one adult to the neonate at the end. All of us know that in neonate, hypoglycemia is a day-to-day work of pediatricians, and it should be taken care of very seriously because it has long-term consequences in case of a neonate. Now the session is open for discussion. Any question?
Sir, I have a question. Sir, when patient is having hyperinsulinemic hypoglycemia, we don't have the scan possible here in Akola, so it takes time. Meanwhile, patient is severely symptomatic. In that case, what can we do for the patient? Meanwhile, we get the scan and proper diagnosis.
Complex carbohydrate diet. Because the insulinoma patients will come to you. They have a long history. If you take back the symptoms date back for the last 6 months, 1 year, few years. So the patient knows how to manage his hypoglycemic symptoms most of the times. If it is a short duration and very severe symptoms, probably we are not dealing with insulinoma. And as a doctor, what we usually do once the patient is with us, we put them on a cornstarch diet where they take a cornstarch which is uncooked. And they mix 2 spoons of cornstarch and drink every 4 hours. That keeps the sugars at least above 50 to 60 and they don't get into severe hypoglycemic symptoms. Sometimes we have to resort to octreotide injections. Subcute octreotide helps because they are DOTA-avid lesions and the octreotide works in insulinoma as well. Sometimes we put them on a small dose of prednisolone, which is twice a day, maybe 10 milligram or 5 milligram to counter the effect of insulin. So that's a symptomatic management for the time being. And I understand the scans are not available because Mumbai to Akola is only 8 hours distance. We traveled overnight. They can do the scan in the morning and come back next day as well. We have a flight back, we have a train back tomorrow. So those distance and other things are not concerns. But again, I will point out the clinical and the biochemical aspect should be confirmed before getting a DOTA scan done.
Even HRCT will identify the...
HRCT will identify, but because these are small lesions, usually 1 centimeter, picking up a neuroendocrine tumor in that pancreas, one will not have confidence to pick it up. So if I have a DOTA and exenidin scan positive, I am very confident what I am dealing on a CT scan is equally important.
Sir, how frequently you come across the patients of hypoglycemia who are having these carcinoid tumors, insulin secreting carcinoid tumors in the lungs or in the other sites?
So ectopic insulinomas, if you are talking about, so there are only 12 cases reported worldwide till date. And we had one which I showed was a jejunal lesion, which I am aware of. So ectopic insulin secreting tumors are very, very rare. Though we have those tumors, other malignancy like the breast malignancy which produce IGF-2, those cases we get once in 3 months from TMH.
But carcinoids in the lungs are not so common.
Carcinoid lung will not produce insulin.
Thank you for the informative talk, sir. I request Dr. Anurag and our chairpersons to please proceed towards the center of the stage to accept our congratulations.